Hello, everyone. I'm Dr. Omar Bey, and welcome to OBHealthy and the Physicians Health Network. We're a group of physicians that come together for a specific reason, number one. And the number one is to improve health in the people of African descent. Number two is to let young African-American males know that it's possible to become a physician. It's so important because we've recognized that our males are not actively going into medicine. We want to encourage them that they can become doctors as well. Understand our webinar is every second Saturday at 1 o'clock. Please let others know, family, friends, to join because we're all about health. And we would love to answer your questions. All righty. If you want to see our past webinars, they're on YouTube. You go to OBHealthy on YouTube and you can see any of our past webinars. Please subscribe so that we can continue to bring these webinars through YouTube, that YouTube channel. All right. The most important thing that I can say today, and I will say it several times, please do not change any aspect of your medical care, no matter what we say, because only your physician can truly take care of your medical problems appropriately. All right. One thing before I introduce the physicians and we're going to get going, I would like to recognize that hold on. Okay. A little technical there. I would like to recognize that we lost one of our brothers, Dr. Alfred Davis. He's a chiropractor, and he passed just recently. Let me see if I can bring a photo of him up because he is one of our brothers that is Dr. Alfred Davis, yes. Dr. Davis, chiropractor, he was one of our original members of the Physicians Health Network. When we were going from church to church, up and down the highway, going from Philadelphia to New Jersey and to New York, he was with us. And recently he passed. I would like to say that to our brother, rest in peace. Number one, condolences to his family, and to just let everyone know that he will surely be missed. Okay, thank you. Right now, I would like to introduce, I'd like each and every one of the physicians to introduce themselves, and we'll get going with our questions. All righty. Dr. Atherley, can you start off for us, please?
Certainly I can. Good afternoon, everyone. My name is Trevor Atherley. I'm a board-certified interventional cardiologist. I practice in the Essex County area, predominantly out of Newark Bethesda Medical Center. Good to be here.
All right, thank you very much. Dr. Court, James Court, please.
Dr. Court, my practice is located in East Orange, New Jersey. My specialty is internal medicine. My primary hospital is Newark Bethesda Medical Center.
All righty. And Dr. Kendall Sprott.
I'm Kendall Sprott. I'm a pediatrician. I did critical care pediatrics for 15 years in general pediatrics, and I'm recently retired as of April 1st of this year.
Excellent, excellent. And Dr. Patrick Anderson.
Hi, everyone. I'm Patrick Anderson. I'm a board-certified obstetrician gynecologist and a practicing gynecologic oncologist. Practice with Dr. Atherley, Dr. Court, and Dr. Bay at Newark Bethesda Medical Center. Glad to be here.
All right. Excellent. I'd like to say that we're going to highlight a specific diagnosis today, and our highlight is diabetes. But before we get to diabetes, I'd just like to get started with, and we don't have any questions coming up yet. Remember, all the public out there, please type in your questions because we're here to answer your questions. That's the most important thing. I'd just like to start off with a diagnosis, something that's in my specialty, which is pulmonary, and that is asthma. and maybe Dr. Sprott and others can chime in with this. Because this time of season, I'm finding in the hospital and in my office that I have a lot of patients coming in with shortness of breath, cough, wheezing, chest congestion, and with a history of asthma. And it's something that we find in our children as well, and it grows into our adults. Understand that asthma is an inflammatory process, an inflammation or swelling in the airways. All righty. And it's characterized by things like shortness of breath, chest tightness, wheezing, coughing. And usually it develops when we're a child and we know we have it. It limits our airflow and our ability to breathe. And there's nothing more frightening to an adult as well as a child than shortness of breath. Dr. Sprott, maybe you can chime in on this and some of your experiences with asthma since you're a pediatrician.
Sure. Well, asthma is an extremely common diagnosis that's made early in children. And there are some things that are associated with asthma that you can see very early on in life. And they call it this, I'll say this trio of allergy, asthma, and eczema. You know, eczema is a condition where you have dry skin. And very often I see babies that have eczema, dry skin, and it occurs in certain areas of the body. It can be very, very itchy. And babies will start to scratch those areas and it causes the areas to sort of spread. So when I see a young baby that has eczema, I'll ask the parents whether or not there is a family history of asthma or eczema, and very often they say yes. And what I say is that there's no guarantee that the baby will later go on to have asthma, but it's a pretty good predictor. As you said earlier, it's a disease of inflammation of the airways. But the airways, if you think about how the airways work, is they serve as a pathway for air and oxygen to go in and out of the lungs. And what happens is that those airways get narrowed with asthma. They get narrowed for three different reasons. One is there's a small a ring of muscles that surround the airways that they can contract. And when they contract, they make the airways smaller. Once those airways get smaller, it becomes difficult for the individuals to move air in, but more importantly, it affects the movement out, because there's a natural tendency when you breathe in for the airways to slightly expand, and when you breathe out for them to slightly contract. And so when you breathe in, the airways open up a little bit, but the airways are narrow due to the constriction of these muscles. Or the other thing is that if they're inflamed, they can have swelling or edema that causes the airway to narrow. And then the third component is an increase in the amount of mucus. Now, there are glands that make mucus, and mucus is sort of a sticky type of material. And that mucus is made, and there's a continual movement of a thin layer of mucus through the airways up and out of the body. And what tends to happen is if those airways get narrowed, especially as the airways get further and further down from the top to the lungs, they can get blocked very, very easily. And if they get blocked, then the mucus that's being made gets trapped. And then the individuals will start to cough to try and move the mucus. And you can see that a lot of the people that are having asthma will start to bring up a lot of mucus. Now, under normal circumstances, that mucus that's thin and moving up is protective. Things like bacteria and things that hit that mucus get trapped on the mucus, and then they move up and then they get out. Usually most people just swallow it because it's not very much. But if you have asthma and it gets blocked, then you can have trapping of air. And so that air that gets trapped that can't move out really limits the amount of air that you can breathe in. And so one of the first things that tends to happen if you're having someone that has asthma is that their breathing rate, their respiratory rate starts to increase. They start to breathe faster. And the reason that they're breathing faster is because over the course of a minute, you're moving a certain amount of air in and out. But if the size of the breath or the volume of the air that you're taking in is less, in order to move the same amount of air, you have to breathe fast. And so, an adult might breathe at 15 times a minute. They might be breathing at 30 times a minute, or double the rate, because the volume of air that they're breathing in and out may be half of what it is. And so you'll see that people that have asthma will have an increase in their respiratory rate. And as you said before, wheezing is a kind of noise that they have. And in general, that wheezing occurs when the airways are most narrow, which is when you're breathing out. And so you'll see individuals that if they have asthma, they'll start to wheeze when they breathe out. If they are wheezing when they breathe in, which means that the airways are extremely narrow, that's really a danger sign for individuals that have asthma, because in general, it's limited to the breathing out phase. But if they're wheezing when they breathe in and they breathe out, they're in really trouble. It's important for individuals that have asthma to know what are the triggers. And the triggers are, as we said, it could be allergy. And the allergy could be something related to food. And very often you'll see that, especially as triggers in the early kids with the eczema. But in the fall and in the spring, when there are lots of things in the air, pollens and things that are related to grass and leaves, those things, if you're allergic to it, will trigger an asthmatic attack. So they'll cause those smooth muscles around the airways to constrict, making them narrow, and that'll lead to the coughing and the wheezing that you normally see. Sometimes individuals might have a trigger just by being exposed to cold air. So if they're inside and it's nice and warm and they go outside, they'll start to cough or they'll start to wheeze. So just the cold air itself can be a trigger. Some individuals will have what we say is exercise-induced asthma. If they start to exercise, then they'll start to wheeze or they'll start to cough. And very often we note that the wheezing is something that's an issue. But even before you start to wheeze, you can start to have these airways getting narrow. And so you can start to have symptoms that lead you down the path. And indeed, when we talk about, what people that have asthma can do, usually you take medications to relieve those things that are causing the constriction. So there's a medicine called Albuterol that a lot of people use, and it's called sort of a rescue. It's short acting, but it causes the smooth muscles to relax. Very often it's coupled, or you can take it separately, an inhaled steroid. Now, a lot of people are afraid of taking steroids, and because taking steroids can cause all sorts of issues in terms of increasing weight and things like that. But if you take the inhaled steroid, the amount of steroid in that inhalation or that breath is very, very small. And the steroid is working topically. It's working where the problem is on the airways. So if individuals have asthma, you shouldn't be afraid to take the inhaled steroids, because it doesn't usually get into the system in large enough quantities to cause all the side effects that you typically hear about when you hear about people taking steroids. Now, the Albuterol, which is the medicine that causes the relaxation of the muscles surrounding the airways, works quickly, but it doesn't last that long. And so it's considered sort of a rescue. The steroids work on the inflammation. And even though it takes a little longer for the steroids to work, it often has a greater effect in causing the airways to open up, because a lot of the swelling of the airways will go away. And some people who have, very bad asthma may need to be on an inhaled steroid on a daily basis. And very often these inhaled steroids will have a difference in the amount of steroids that might be in them. So they might have 3 different strengths with some of these combination medications. The amount of medication, if it's in a combination, that causes the muscles to relax is the same in all of those 3 different types of medication. Because sometimes these short-acting medications like Albuterol not only will cause the smooth muscle to relax and open up the airways, sometimes they can stimulate the heart and cause the heart to beat faster. And sometimes that might be a problem if people that are having an attack take too much of that Albuterol even before it's fully worn off, because they don't feel any improvement. It sometimes can cause problems with the heart beating faster. And so it's really, really very, very important for people to kind of understand if they do have asthma, what are the things that trigger it? Now, the good thing about the childhood asthma is that a lot of individuals that have asthma, as they get older, the airways get bigger. And if they get bigger, it takes a little bit more for them to get small enough to they might have symptoms. But very often, even if they get older and they have less frequent attacks, that same kind of trigger might be there, and it might cause them to flare up if they're a teenager and an adult and have that happen. Now, the other major trigger for asthma is upper respiratory tract infections, usually viral infections. And one of those viral infections that might be thought to be a contributor towards the later development of asthma is a virus. It's called Respiratory Syncytial virus, or RSV. And this is the time of year that we normally start to see these kinds of infections. Influenza is another it sort of starts upper respiratory, but then it gets lower into the respiratory tract. And the same with respiratory syncytial virus. It gets down to the lower airways, and it's associated with something we call bronchiolitis. Now, we talk about the airways, the trachea, and then the bronchi, and then the smaller the bronchioles, and that's where they cause the damage. And these viral infections, this respiratory syncytial virus, actually destroys those cells that line the airway. And very often, individuals that have respiratory syncytial virus will have a cough during the acute phase of the disease that might be 10 days or so. But very often, because they've destroyed these cells that line the airway, and those cells I talked about before sweep that mucus up. If they aren't there to sweep the mucus up, then that mucus stays, and then the only way you can get that mucus out is to cough. And so individuals that might have respiratory syncytial virus may have a cough that might last 3 or 4 weeks even after their initial symptoms go away. And once having that viral infection at that age, a large number of individuals go on to wheeze or to have asthma after that. Now, whether or not they'll continue to have it as they get older is a question. But when we talk about the triggers, it's important for people to understand that the asthma, if it's an allergy, you stay away from whatever it caused you that might cause the attack. If it's sort of inhaled, like in the spring and then fall with things that are in the air, it's difficult for you to do. And sometimes you might take some medications that deal with the symptoms, because it's not just asthma. A lot of those folks that have allergies will have allergic rhinitis, which is a runny nose, or will have conjunctivitis, where the eyes are running. And so there are a lot of different ways that those things may manifest. But if it's causing an issue within the lungs, there'll be a cough associated with it, or a tickling in the throat that you may have.
Right. Can I ask a question? Now, the way you explain it primarily talks about noxious stimuli that triggers an event in the lung itself. Is there another organ system that can influence the lung that does not involve an external pathogen like a virus or allergens such as pollen?
Well, one of the key components that occurs with some of these allergic reactions is the release of a chemical called histamine. And a lot of people know that if they have colds and they have runny nose, that they might take an antihistamine, which is to counteract this chemical histamine that causes increased blood flow, can cause this release of fluid temporarily, but it's a release of fluid as part of this allergic reaction. There are some medications that you can use if you have those that sort of decrease the ability of those cells that have the histamine to release the histamine. So sometimes you can take medication. One of them is called cromolyn, and they can do it. They have it for eye drops if you have allergic conjunctivitis. You can do it for the nose if you have the allergic rhinitis. And the same thing, they have topical steroids for the eyes and for the nose, because there are other areas that are affected. It's not just the lungs, and as I said before, those individuals that have eczema, it can affect the skin. And some individuals will also have the same kind of I'll say, reaction in their gut. And so you can have individuals that have these cells that release histamine in the gut and causes this, and they can have diarrhea associated with it. So there are a number of things that are affected. And if you have the trigger, especially with the lung. This natural release of adrenaline, and way back in the day, Trevor and I will remember, and maybe James, you're as old as us. When people had asthma, they would come in the emergency room, we'd give them a shot of epinephrine or a shot of adrenaline. And it works very, very quickly. But man, would the people know that they had been hit with something, because not only did it cause the airways to open up, it caused their heart to beat like crazy. And so they started to, over time, develop drugs that didn't have so much of the side effects or the effects on the heart. But adrenaline is something that is released. They call it flight or fright. And a lot of individuals that have asthma, if you have trouble breathing, it's one of the most miserable things that you can feel like. And so you get very, very anxious. And adrenaline gets released naturally that might have some effect. But in general, we used to give them 2 hits of epinephrine every 10 minutes, and then give them a longer acting epinephrine and send them home if they had to release. But there are a lot of things that are associated, because it's not just the lungs, but because if you can't breathe, you don't live. You can have affected when you have this kind of attack, because these and again, that's sort of allergies. We don't know exactly what's going on with exercise, how exercise might cause you to have it. But we certainly know that if you're talking about viral infections that affect the respiratory tract, from the nose to the lower cells, those things will usually have respiratory kinds of symptoms.
All righty, excellent. Dr. Sprott, we're going to have to feature you for some of the main medical problems with our kids, and bring you on as a feature, because there's so much that I think a lot of times we talk about adults so much, but we kind of miss some of the things that our children experience. Thank you. Dr. Aluya, can you pull your mic on, please? Open up your mic.
Sorry.
Can you introduce yourself?
Yes, my name is Nelson Aluya. Sorry, I came in late. I was having a little bit of problem logging in. He kept on asking me for password and password. I'm like, I never had this before. Why is he asking me now? So, I call myself a medical advocate, as I always do. I'm a medicine pediatrics trained, assistant professor of medicine at Rutgers, also an attending at Newark Beth Israel Medical Center, where I see adults as well. And glad to be here, and a pleasure being in the midst of my great and big brothers and esteemed colleagues who will teach us good things this afternoon. It's a pleasure. Thank you.
Thank you very much. We're going to turn our direction towards diabetes, because just to emphasize the effect of diabetes that is on the African American, and I should say anyone who is a descendant of Africa. It seems as though diabetes is one of those diseases that has completely overwhelmed this part of the society. So we're going to talk about diabetes today. Dr. Aluya, there is a question that's come through. This is a question from DJ. It states, please clarify the definition and borderlines of type 1 and type 2 diabetes. Can you start us off, Dr. Aluya?
Well, I always like to start things historically, so that we get a great understanding and foundation of what it is. Diabetes is a disease that obviously affects every tissue in our body. And why is that? Because every tissue, like every living thing, depends on glucose. And glucose is the power, the energy material that every living thing needs to exist, to produce its other cells, to produce hormones, to produce defense mechanism, everything that is needed. So once that goes wrong, every cell goes wrong. Now, why is this particularly, and somebody did ask me, why is it that it's bothering us as people, as African Americans, or as people of African descent? The teaching back in the days is diabetes is new to Africa. It's new to our DNA. In the 1980s, it was only said that about 800,000 people with diabetes in the continent of Africa. If you know the African continent, as at that point in time, was just about 1 billion people then. But today it's 1.3 to 1.35 billion people. And from then till now, 2015, there were just about 15 million people. Today, about 21 million people with diabetes in Africa. And people begin to wonder why. Lifestyle changes, a whole lot of things that's taking place. Now, going back a little bit, anthropologically, life began in Africa. We all know that. Scientifically proven, and no doubt about that. So those who are the Caucasians that live in the Western world left Africa 30 to 35,000 years ago. So, and that's what you all see. If you look at the genetics, there's the M1 gene, there's the CRP gene that eventually became, those of Asian, descent, and those who moved to become the Caucasians, and then eventually those who came to the, North American continent. Those who you see today are those who survived the process of evolution that took place. So their DNA was able to sustain and contain what they have. Now, we as a people, we only left Africa 500 years ago, even if we were moved on out of Africa forcefully or not. So our DNA is really new to our environment that we live in right now. So the 30 years that those who left ahead of us has been given time to adjust. We are just trying to adjust. So that's why a whole lot of all these diseases is affecting and having a whole lot of debilitating effect on us. Now, coming down to the disease entity and description, there are different types of diabetes, and over the years, there have been descriptions for it. Now, going back again into history, some of the early first description of diabetes was actually done in Egypt. There are hieroglyphics that shows, how they described it. The diabetes mellitus, the term, all of those things, abnormal sugar, sweet urine, all of those descriptions were already written down in the hieroglyphics, the Egyptian way of writing. And so we've known all of this over the years. But then the description of what we have today into type 1 and type 2, those are the basic two descriptions. But then you also have those who are pregnant, that is called gestational diabetes. Now, out of the type 1 and the type 2, there have been a few descriptions that have been in the process and some removed. Now, there's what they call MODY, maturity onset diabetes of the young. This was way back in the 1980s to 1990s and early 200s or 2000s, where individuals who were neither type 1 or neither type 2, but they were young, usually very obese individuals. But then we begin to see a little difference of what things are looking now. They're no longer that young, and they're not obese anymore. So, but some of them are young. So they took away all that description of MODY, maturity onset diabetes of the young. So that's been kicked out, and they replaced it what they call LADA, latent autoimmune diabetes of the adults. Now, those individuals are usually skinny, no history of diabetes, and they present like type 1. So now basically I have three descriptions: the type 1, the type 2, and then the LADA. The LADA on a colloquial level, on the street level, we call it type 1.5. So you have type 1, type 1.5, and type 2. And I'll describe each one. Now, the type 1 is usually when you have the pancreas. The pancreas is the organ that is usually on the left, right just below the rib, on the left side, that produces the product insulin that help regulate the body to absorb sugar into the system. Now, if the pancreas is diseased, meaning it can produce. There are special cells, insulin cells, that produce those insulin. Now, if the cells are diseased, it cannot produce insulin anymore. Now, for those individuals, that's a type 1, meaning something really bad happened to the pancreas. It could be from a disease, it could be from a drug, it could be from an infection, and a lot of the time it's from an infection, especially a viral infection. And we've known that during the fall period and the onset of winter, that's when a whole lot of type 1 tend to occur, especially with young kids. And those ones tend to happen in young kids. Now, there's also genetic pre-deletion as well, in the sense that some individuals, I know of a family, that all the girls, all of them, once they get to age 13, they all become diabetic. I had a patient who, all the sisters, except the boys were fine. All the girls were all diabetic. And then she's like, oh, well, I have a sister, she's 11 now. I'm like, oh, really, she's not diabetic? She's like, yeah, I know she's going to be diabetic when she's done 13. So over the years, I saw her, and I saw her again 2 years after. I said, oh, so how's your sister now? Oh, I told you she's going to be diabetic. She turned 13, she became diabetic. So we know that there's genetic predisposition as well to those who have type 1. Now, in those cases, the pancreas is not producing at all. So the insulin that's helped to absorb the sugar that we eat, that's broken down from all the food that we eat, broken down by the liver, is defective. So no insulin. Those are individuals that really need the insulin. Thank God the insulin was developed, I think about 100 years ago now. Before that, a lot of these people died. Now the type 2. The type 2, again, still desired, you need the insulin, but the problem is this, that there's what I call insulin resistance, meaning the insulin has to get onto certain receptors in the body for it to get into the system. But if those receptors are defective, the insulin is not going through. Or for some reason, something alters the genetic composition of the insulin. I'll use the typical example. Maybe something coats it, somewhat like that. Coats it, that it gets to the receptor, it can't get in. So in those individuals, those are the ones that have type 2, meaning they're usually adults, and over time, they're normal, no issue, no problem. As they go on, as they gain weight, as they increase their, there's increased sedentary lifestyle, meaning they're not active as they used to be. They eat certain kind of food, or certain kind of disease itself, or certain kind of treatment, post-chemotherapy, or steroid use. All of those things increase the resistance of your insulin working and your body absorbing the sugar. So there's type 1, and that can happen in any age. We've had a few months old babies who become type 1, and those who eventually later in life, for some reason, become type 2. Now the type 1. And then the type 2, those are individuals who usually are adults, increase insulin resistance, and the insulin is not getting in. Why is it important? And then I'll talk about the type 1.5. So those ones, again, it's usually, we now know that those individuals, there's an autoimmune process that's taking place. It's something that was actually, it was in the literature, but became a mainstream within the last 5 to 7 years when this description came up. So they start as type 2, meaning there's increased resistance to the insulin. Now we know it's an autoimmune process, meaning like lupus, like Strauss, all those diseases, like even thyroid disease, where the immune body produces either from a virus or something triggered somewhere, it affects the pancreas, so that, and affects the way the pancreas produces the insulin, and insulin can't get into the system. So because of that, they come out like type 1. So they need tablets to take. So they take the tablets, but over a while, you find out that you take 1 tablet, it's not working, 2 tablets, 3 tablets, still not working. Then you now need insulin. So, but at that point in time, when you look into the body and the pancreas, you find out that the body is producing immune response saying there's an attack to those special cells in the body. So that's the type 1.5. So they start with type 1, the type 2, they take the tablets, but as time goes on, they have to need insulin. So those are the 3 major descriptions. But then there are individuals when you're pregnant, so those who are pregnant, because of increased metabolism, increased weight, increased circulating, all those big stuff that's going on during the pregnancy stage, the increasing resistance as well. So those women tend to have a high amount of sugar in the system. And that circulating amount of sugar also affects the baby. You find that those babies are really very big, and when they're born, the sugar might actually affect the way the individual cells begin to develop, and they have some problem, neuroceptal defect, heart issues, and all that. So when the babies are born, they're big, and they tend to have metabolic process that may need them to be seen in the pediatric ICU for a longer time. So, but usually after the pregnancy, it tends to resolve and goes back to normal. But those individuals tend to have 26 to 30% chance in the future of having diabetes. And that's why it's so important that we keep an eye on those.
All right.
Yeah,
Thank you. Go ahead, Patrick.
No, I was just saying,
Patrick, hold on, just for a second. Dr. Salam, could you turn on your mic, please? All right, can we get Dr. Salam to introduce himself? And then Patrick, we're going to go with your question.
Yes.
Good afternoon, everyone. My colleagues and everyone present for this webinar. My name is Dr. Kareem Salam. I'm a board-certified adult and child and adolescent psychiatrist. I practice in the city of brotherly love and sisterly affection, more commonly known as Philadelphia. And I'm delighted to be a part of Physicians Health Network. My apologies, I'm running late. I had to make rounds this morning, but it's a delight to be here. And I know our topic is an important one for our community, diabetes mellitus diabetes. So glad to be here.
I'm going to ask you a question in a minute, Dr. Salam, but Dr. Anderson, go ahead.
Yeah, no, I was saying, Dr. Aluya explained how diabetes develop, and it's an issue with insulin, either lack thereof or lack of response to. And, it just doesn't often happens in an isolate. There are conditions that are syndromes, and those speak to some of the autoimmune nature of the development. So for example, hypothyroidism, autoimmune, premature ovarian failure, many young women going into menopause very early, is that autoimmune mechanism not just affect the beta cells in the pancreas, but also affects ovarian cells, affect tissues in the thyroid, and lead to early onset diabetes and disruption in multiple of the endocrine processes that occurs in the human body. On the receptor side, from a woman's health perspective, the lack of response. So in pregnancy, we often say pregnancy is a diabetogenic state. And women who develop gestational diabetes often signal that in the future they're at risk, because we know their receptors are susceptible to not responding to insulin, either because it's a competitive system where it competes with other substances for sites on the receptor. Patients who are exposed to steroid hormones, who develop obesity, they do develop insulin resistance. Intrinsically in the ovaries, there are processes that affects ovulation and ultimately causes derangement in the sex steroids. So for example, the polycystic ovarian syndrome, these patients often have insulin resistance. So at a very young age, you see they have very high hemoglobin A1C. Often you not just manage it with hormones, but also with trying to control their blood sugars. So, it doesn't happen as a single entity, not just what it can cause, but what causes insulin resistance and lack of production.
I have a question for Professor.
Go ahead, Dr. Court.
I have a question for Professor Aluya. I'm a little confused. If you have a patient who is in their 30s and initially they came with a blood sugar of 400, you start them on metformin or whatever, and subsequently that patient's blood sugar is not controlled. and that patient requires insulin. From what I heard from you, I think you would probably have to classify this patient as a type 1. Am I right?
You're on mute.
You're on mute.
Yeah, type 1.5. So if you have a young individual who
There's someone in their 30s, yes.
right in their 30s, because again, it's taking a full history. Is there a family history of diabetes? Is he on drug medications that predispose them to diabetes? Is there risk of cancer? Is he taking any other drug that put them at a risk as well? And some of them we tend to forget there are individuals who also take multivitamins, and you'll be shocked. And I've always told people, please, when you take those multivitamins, confirm where they're coming from. Hopefully it's not one of those vitamins that's being, cooked or brewed somewhere in the backyard of some Vietnamese, individual and sold all around and it's for free or something. You got to be careful, all of those things, because we've had individuals who take vitamins whose pancreas failed and they become type 1.5 or type 2 eventually. So these are issues you need to set. But by all of those, there's a little family history of diabetes, but the guy is slim, he's 30s, and you start, and sugar comes out really high. This is the time to actually, as you're doing the blood work to see what's going on, check the antibodies, the anti-GAD antibodies, and a few other ESR, CRF-protein. You see that those things are positive. If they're positive, it tells you that they're type 1.5. So you may start with tablets, but over time, you find out that you may need to put them on insulin. But one of the things I've also done, right? One of the things I've also done is great education. I have to tell them, like, listen, one, stop soda. All those soda you have to stop right now. If you're drinking beer, stop it. And then you have to have an exercise regimen every day. And I tell them, because nobody wants to be on insulin. I said, look, do you want to be on insulin? Or do you want to have complications that anybody in your family have? Because I will always ask, is there anybody else in the family with diabetes? If they say yes, and I always ask again, the follow-up question is, what complications did they have? Because if it's kidney, most likely that's what they're going to get. If it's blindness, that's what they're going to get. If it's a heart, that's what they'll get, because that's what the DNA is going to say. So, and I say, look, if your father had kidney or amputations, that's most likely you will have. So if you don't want to go there, then one, cut away soda, the food you eat, the carbs, and a lot of all those fast foods and all that, and then exercise. You have to have an exercise regimen, and then follow up so often, and you find that they do well, and then we put them on meds and we'll continue. But of course, a few of them will not listen, and then eventually end up on insulin. But then some of them get an awakening, and then they do the right thing and they come back.
So, Omar, Dr. Luya likes to go into the history of things. I like to focus on the normal, right, which is how things work normally. Insulin, as he said, is a hormone that's made by certain cells that are in the pancreas. But insulin is usually not measurable under normal circumstances. It's only released in response to an increase in the blood sugar. And that occurs from when you ingest either sugars, carbohydrates, insulin is released. And what happens is, as you eat something and that sugar gets absorbed and raises in the bloodstream, insulin is released almost immediately to keep that blood sugar level within very narrow limits. And then once it gets into the very normal narrow limits and it starts to go down, it cuts off. And so there's a range of normal blood sugars that when everything is working fine, you're okay. Now, when we talk about what does insulin do? Insulin, as Dr. Luya said, facilitates the entry of glucose, which is a single sugar as opposed to a disaccharide, which is a double sugar. It facilitates the entry into cells. And all of the cells need insulin except one type of cell, the brain cells. The brain cells do not need insulin in order to absorb glucose. And the brain cell needs two things. It needs oxygen, as all cells do, and it needs glucose.
Okay.
It can't function unless it has glucose. So there always needs to be a certain level of glucose in your blood. But indeed, if you are normal and you ingest carbohydrates, starches, and sugars, and your blood sugar goes up, insulin is released, it keeps it in a narrow range. Once it hits below a certain level, it cuts off. So if you are all of us try and take a blood test and see whether or not we have any insulin, we probably are going to have no level of insulin. Now, as he said, if someone has the damage to their pancreatic cells, those cells that make the insulin, and they're destroyed, then you can't release insulin because you're not making insulin. Okay? And then you become diabetic. Because anytime you eat starches or sugars, carbohydrates, the blood sugar will go up. There's no insulin to keep it within a narrow range, and it'll go up. Well, how will it go up? It'll go up to a level of about 180 because indeed your kidneys filter the blood, filters the carbohydrates, and then reabsorbs. Once you get to 180, it can't reabsorb what's being filtered, and then it'll spill into your urine, and it'll pull water with it, and you'll start to become dehydrated. You'll have increased frequency as it relates to that increased glucose that's leaving the body via the kidneys, and you can become dehydrated. And those kids will have that. So in addition to it facilitating the entry of glucose into the cells, it also promotes the development of fat. And if you have excess calories, because you've had those starches and sugars, they will be converted into fat, and you'll increase your production of fat. Now, in general, fat is sort of a way that you store energy. Now, if you don't have insulin, in addition to pushing sugar or glucose into the cells, it also pushes potassium in the cells. If you don't have insulin around, okay, then you don't have that facilitated entry of sugar into the cells, but you also start to break down fat, okay? And as you break down fat, there's these fats that get broken down, they call ketones, and you start to spill those. And when people starve, that's how they generate energy, is they break down the fat, and you can use that as an energy source. Now, the problem with that is that those fats that are stored can't be converted into glucose. But I was a product of a mother that had diabetes. I was 10 pounds. You might not believe that. That was a 10-pound baby. And the issue with the babies of mothers that have this gestational diabetes is the mothers are not able to regulate their blood sugars. The blood sugars go up. The baby gets exposed to that excess glucose. They have no trouble with their insulin, and that insulin causes that excess calories to get converted into fat. So they're these fat babies, and because they were exposed to this high level of glucose in the mother. The danger occurs when they're born. They're no longer exposed to that high level of glucose. They have that high level of insulin, and the blood sugars can plummet dramatically, which can be a big problem to the brain. And so when you think about these individuals that have diabetes and these issues related to high blood glucose levels, individuals that start to become obese, in general, they become obese because they are taking an excess amount of sugars and starches, carbohydrates, okay? If you just ate protein and fat, since they don't have sugar, your blood sugar doesn't go up, you don't release insulin, and because you're not releasing insulin, you're breaking down fat, okay? So the individuals who are become diabetic, the amount of insulin that they really need is going to be related to the amount of carbohydrates that they're going to be taking. The more carbohydrates they take, then the more insulin that's going to be required in order for them to regulate it, to keep it normal. And that's what happens with a lot of individuals that have this type 2 or adult onset. They increase their diets in terms of what they have in terms of carbohydrates. The body has to make more insulin in order to keep it under control. And so they have higher productions of insulin than normal. Over time, their production of insulin, even though it's very, very high, isn't able to keep it regulated. And so in general, if you were to look at what happens when you ingest carbohydrates, your blood sugar goes up, your insulin follows it, it goes down and not. For those individuals that sort of, you talk about insulin resistance, once they reach a certain point, they release insulin fairly quickly, but it goes a lot higher than normal because their blood sugars remain higher, and it takes a longer time for it to come back down to normal. And at a certain point where they're not able to regulate it, then they start to have these higher amounts of glucose and then start to have these same sort of symptoms associated with it. And so what you find with a lot of individuals that are placed on medications to help with their blood sugar, especially those that have type 2 diabetes, you think about it, they're already making a tremendous amount of insulin. They don't have insulin lack. And what you say is, well, what we need to do is we need to give them even more insulin in order to regulate them. And so they're already making lots of insulin, you're giving them more insulin, and that excess calories is still going to convert it to fat. So what they really need to focus on, and this is your issue, Omar, is they need to do a diet assessment of what they're doing. And again, if they were to cut down on the amount of carbohydrates that they take, then the amount of insulin that they would need to regulate it becomes less. And if they lost weight, you would see that their ability to control their sugars gets better and better. We had the bariatric surgeons that showed that individuals that were very, very obese and they had to bypass surgery, they had diabetes. Some of those individuals stopped having diabetes as their weight loss started to fall. And part of that is related to the fact that these bypass surgeries decrease their ability to take in food. And the foods that they decrease in intake is carbohydrates, and that has a dramatic effect on their need for insulin. So people need to understand that relationship between insulin and starches and sugars, carbohydrates. The less carbohydrates that you eat, the less insulin you need to regulate it. Even if you're diabetic, the less insulin that you'll need to regulate it.
Nelson, can I ask a question of Dr. Alou here and maybe make a comment?
Dr. Anthony, hold that question.
Sure.
I know this is a hot topic, and we're going to, Dr. Salam. Okay, we have a question here, and there's a patient that states, and the reason I'm answering this question, and I want to preface the question first. There may be in our culture, not maybe, we seem to be obese or overweight. And that's the type of person that may have type 2 diabetes. Is there something in our culture psychologically that causes us to crave that carb or that sugar, or something that, is there a reason culturally that we are gaining weight that leads us to this diagnosis? Now, let me get to this question. That's one part. The second part was that someone states that they have diabetes and they eat once a day because they're afraid of their blood sugars going higher. Now, we're going to address this as well, because you understand that one time a day means that the blood sugar is going to go even higher if you eat one meal a day, as opposed to 4 or 5 small meals a day. But
Omar, remember that one meal a day, in order for the blood sugar to go high, has to have a high amount of carbohydrates.
I understand that too.
If it's not, then it won't.
It won't, right. But Dr. Salam, can you chime in? I know I prefaced a lot, and I know you had a question as well, but let's get that, and then we're going to go to Dr. Atherley, okay?
So in terms of any cultural contributors to certain food cravings or food in general that could lead to an elevated body mass index, I think we ought to take a step back and look at many of the foods that are linked to our group culturally. And for example, we just exited Thanksgiving, right? So things like sweet potato pie, mashed potatoes, stuffing, or things that were commonly referred to as soul food, right? Things that resonate with our palate, but they tend to be high in carbohydrates, high in saturated fats, and these could have metabolic consequences. So on the one hand, the more you educate yourself about nutrition, and I'm sure, Omar, you could speak to this, you realize that these highly refined and processed foods have more metabolic consequences than whole grains, fruits, and vegetables. And let's say you didn't come up eating, for lack of a better term, whole foods, but that's something you have to adapt to or adopt in the service of improved health. So there are cultural rewards to eating these foods that could have these metabolic consequences. I would never recommend to folks to fully abandon these foods, but you have to be aware of the quantity of these foods that you're ingesting. But in terms of anything in our genetic makeup or anything in our experience that places us at higher risk for certain eating behaviors, I'm unaware of that.
Dr. Salam, if I might ask, similar to salt and other substances, is there an addictive component to the whole approach as to how much we ingest, whether it's sugar, salt, caffeine, and those kind of substances?
Now, again, I don't think we're more prone to this than any other group, but we are hardwired to have a strong preference for foods that are high in salt, high in sugar, high in saturated fats. And I think the layperson's way to look at it is these foods, they just tend to taste better. And so there's a greater reward when we ingest them, we feel better. This is the whole concept of comfort foods. And so you could have folks who are eating highly processed foods that may have been prepackaged and have a high sodium content, and then the foods are cooked and additional salt is added. So we absolutely have a preference for these foods based on how they taste. But again, you know, we shouldn't fully abandon these things because we want a modicum of enjoyment in life. Things have to be, you know, we have to consume these foods in moderation, and we also have to broaden our dietary palette and make sure we're including fruits, vegetables, less processed foods, more whole grains and the like.
Doctor,
Yeah.
let me just say one thing. Let's look at it this way. And I want to ask you a question, Dr. Salam.
Sure.
With African Americans or people of African descent, and if you note that we are, as a people, larger. I mean, it's so obvious. I walk down the street and you know that we're overweight. Is there a component in psychological literature that states that a certain culture, for instance, African Americans, there are not too many things that we truly control in our lives. But one thing we can control is what we eat. And that gives you pleasure. So there are certain pleasure centers in our brain that once you eat, that pleasure center is triggered. And if I use food as a pacifier, because that is one thing in my life that nobody else can control like I control, do we think about it like that from a psychological point of view? Just give me your impression.
Sure. Again, you certainly could view it that way. And if you look at it from a socioeconomic standpoint as well, and how look at different communities' ability to marshal resources and what they can do in terms of exchanging gifts or, so we often want to have meals and share meals with people, or you bring guests into your home, you want them to stay and eat because that's something that might be more affordable. It doesn't require a lot in the way of resources, and it's a way to communicate love, affection, and connection. Okay, so absolutely, it's within your ability to make someone feel better by feeding them. And then, of course, you want folks to enjoy that experience, and that's related to the taste in the food and how the food makes you feel. And again, it brings you back to the concept of comfort foods, right? People don't view the fruit tray as comfort food. They view foods that are high in salt, Look at where I do my work in Philadelphia. What's Philadelphia known for, right? Cheese steaks, right? High in salt, high in saturated fats, soft pretzels, right? High in carbohydrates, high in salts. These are foods that increase your risk of not only diabetes, but something called metabolic syndrome, which I can discuss that maybe a little later. But there are some of the medications that I prescribe. One of the constellation of side effects of those medications is in fact metabolic syndrome that's associated with an elevation in cholesterol, blood sugar, abdominal girth, body mass index. But yes,
I think what we're experiencing here is the fact that this is a disease that is a multifactorial, has multifactorial components, right? So now we talk about insulin production. Insulin production, we affect the beta cells in the pancreas. There are other complements that Dr. Athley can speak to, right? Diseases that deposit substances within soft tissue, right? Amyloid, hemochromatosis, Wilson's disease that deposit copper in the liver and the pancreas, that does affect production by influencing these beta cells. Then when we talk about come to the next extreme, we talk about ingestion, right? And processed food. What does that mean, processed food? You process food, you make sugars from complex substances to simple substances so they become immediately available. That immediate availability of sugar speaks to what Dr. Sprott was talking about, the immediate release, that immediate insulin response. So it's kind of like saying, if you create a system or a scenario where it's a balanced approach to the ingestion and management of sugar, appropriate insulin production, appropriate availability of sugar, appropriate response to the sugar, and the appropriate availability for the glucose to get into the chemical reaction, if we can strike that balance, then and the receptor piece of it, then just maybe we create the right scenario as to how to manage how much, when, the magnitude of the response, and that will create that that environment that we need for appropriate metabolism.
I wanted to ask Dr.
Dr. Athley, it's your turn. It's your turn. Okay.
Yes.
And then Dr. Court, it's your turn. Okay.
All right.
And then
I wanted to have.
We're going to take a break. Go ahead.
I want to ask the opportunity to ask our expert, Dr. Aluha, since we do recognize the difficulty in controlling the blood sugar, the need for discipline in taking medication adequately, and the need for discipline in observing the dietary restrictions that we have mentioned. Is there a way to even more strongly convince these patients of the need by expressing what is the need to control the blood sugar? What are the consequences of diabetes? How does it affect other parts of the body? I can mention from my viewpoint some of the consequences of diabetes on the heart, since you know that the commonest cause of death of diabetics is ultimately death related to cardiovascular disease, that is disease of the heart and the blood vessels. And it is very clear the association between diabetes and heart disease. We're all very comfortable with the documented relationship of diabetes to the formation of blockage of the arteries to the heart and the presentation then in these patients of heart attacks. A similar process occurs in arteries elsewhere and can cause disease of the arteries to the lower extremities, for example, disease of the arteries to the kidneys, and of course to the brain, where they can suffer strokes. Diabetes may be one of the components that predisposes patients to these. It is also more recent, there's been more recent information to suggest that even without blockage of the arteries, of the large arteries as we know them, that diabetes itself can cause cardiomyopathy. This is a malfunction of the heart, without the obvious blockage of the coronary arteries, but merely because at the cellular level and the level of smaller blood vessels, that there may be some damage, there may be some unusual responses of the heart muscle to the diabetes, that in fact it may then fail to function adequately as a pump, which is its basic function, of course. So patients may manifest heart failure, failure of the heart to function adequately, of course, manifested by the signs of accumulation of fluid, lower extremities, lungs, etc., or fatigue, shortness of breath, but just overall an inability of the heart to do its job to pump the blood properly throughout the body. And of course, atrial fibrillation is now recognized as the commonest irregularity or arrhythmia in the heart in older patients. And we have documented clear relationships between diabetes and atrial fibrillation. So in a sense, we see the multiple manifestations of diabetes in heart disease. So I'm going to ask about other areas and areas in which you think that we can assure patients, not assure, but inform them of the consequences and the concerns if the diabetes is not controlled. Nelson, what are the consequences?
Yes, I'll tell you this, and I say it this way, and I've said it, on this panel before and everywhere I go, that each and every one of us ought to know what our diabetes status is. Meaning, wherever you are, whoever you are, whatever discipline or occupational or socioeconomic status, know your A1C. It begins from there. And as a matter of fact, as from age 10, I tend to screen everybody. I mean, especially if they're obese. So everybody, those who are listening, share the news. In fact, there's a common saying that if you hear good news, you listen. There's an African saying that if you hear good news, you listen with both ears. So please, listen with both ears. Everybody ought to have know their diabetes status. Know what your A1C is. It tells if you're one, pre-diabetic or no diabetes, or you have diabetes itself. So what's the essence of what pre-diabetes? So if you're 5.7 or less, your A1C, which is the measure of what your sugar is in the last 3 months, because we use a system to do that. You can discuss with your primary and tell you why that is the case. The A1C would tell you either predominantly one of them. We have fructosamine as well, but we use more A1C to tell what your sugar has been for the last 3 months. Now, 5.7 or less means you have no diabetes. But 5.7 to about 6.5, that range is a range where you describe a pre-diabetic. And then 6.5 and above with symptoms will tell you you're diabetic. So you need to know where you are. So if you know where you are, if you are not diabetic, then over time, if you, maybe last year you saw you were 5.4, the next year, when you do your annual, check again to see if you're 5.6 or 5.7. I'll give you a typical example. I had a young guy who worked at the hospital. He was 34 years old. I screened him one time, he was 5.4. The next day I screened him again, he was 5.6. So, and then the following year, three years in a row, I screened him, he became 5.7 or 5.8. I'm like, oh, you're now pre-diabetic now. So you have to watch what you eat, exercise and all that. Of course, you say, yeah, doc, no problem. 6 months down the line, he ended up in the ICU in the ER because his sugar was so high. All of a sudden, he couldn't see. He couldn't see. He was peeing a lot, all of those things. So these things, people just don't become diabetic all at one time. It creeps up. Now we live in a time with technology to tell us that you either were pre-diabetic or you're no diabetes, you're pre-diabetic, and you're diabetic. If you're in the pre-diabetic state, you begin to take active actions to prevent yourself from becoming diabetic, full-blown. And I described that in the office so that we all know that, because that's when you intervene. Now, why did we know about this, or why are we talking about this? Because for the longest time, we had no idea. Most people just show up in the ER, they're diabetic now. So, but in 2013, before that, maybe 5 years before, we're talking about, the entity of pre-diabetes came on. And that's why we began to know that in this country, there are about 30 million people who are diabetic and about 89 million people who are pre-diabetic. And it therefore means that out of those who are pre-diabetic, 40 to 45% in the next 4 to 5 years will all become diabetic. So if you know your status, you begin to intervene at that point in time. You have a straight up discussion with your doctor and then come up with a plan. You need to see a dietitian. You need to, pick up exercise, all of those things, so that you can save yourself. Why are we saying this? Because we began to look into this. in this country, with all the amount of money and all the research and everything that's spent on diabetes, over 600 million, over $60 billion, a lot of money being spent and on diabetes alone. But in diabetes and diabetes related conditions, we're talking about almost $400 billion. Yet we still have people who go blind. We still have a huge number of people who are on dialysis. We have 4 people every day who gets their legs amputated in this country every day. So that's why they said, you know what? We need to find a way where we decide who is at risk and who's not. And that's why the entity of pre-diabetes came up. And 2016, the WHO and the CDC particularly described diabetes in this country as an epidemic. And I say all around, diabetes is not an epidemic, it's a pandemic. It's a pandemic before the pandemic, and it's affecting everywhere and everybody across the globe. Now, coming to Dr. Atherley's question, why it's important that we begin to pay attention and know what your status is so that you can intervene. Why? Because it affects every cell in your body, from the head to the toe. From the head, we talked about strokes. We talked about risk of Alzheimer's. From the eye, blindness. All of a sudden, you find out that the things you used to read, you can't read no more. Oh, it's old age. No, it's not just old age. Go look. It could be a risk for glaucoma. It could be a risk for cataract. Because what happens is the sugar also gets into the eye metabolizes the sugar. So as the amount of sugar circulates in your system, it goes into the anterior and the posterior portion of the brain because separated, by that membrane and the lens. And there's exchange within the eye. Now, the amount of sugar goes in and comes back, goes in and comes back, metabolized. But after a while, if it's too much, there's what they call inositol that begins to accumulate in the eye. And it changes the way light passes through those throat chamber. And that's where you can't see properly. And if the inositol continues to accumulate, it puts you at risk for cataract. That's why it's important. Now, that's the eye. Now, coming to the neck and swallowing, you can have problem what they call gastroparesis. You have problem absorbing food when you eat. Now, if you come to the heart, Dr. Atherley talked about it. Risks for arrhythmias, risks for coronary artery disease, and even affectation of the valves. There's a particular way that affects the valves. We talked about it before, where in this country, before the antibiotics and all the infections, the vaccines that they gave for strep pneumonia, we have no idea what those vaccines did for our children. Because in other countries, they still have strep pneumonia that affects the heart, where it's an autoimmune valvular heart disease that affects. Now, the way it affects the valve, it actually affects the root of the valves. But with diabetes, it affects the leaflets. So with those other diseases, you can put a valve and a prosthetic valve, and it attaches to the valve. It works with other diseases. But with diabetes, it affects the leaflets. So it's really hard to put a prosthetic on the leaflet. That's why it's so important. Now, that's the heart. Now, coming down to the kidneys, geez, it's the #1 cause of kidney failure in the world, followed by hypertension. So if you have that, we have a whole lot of us who are on dialysis. What's the percentage of African Americans in the country or Black? About 13 to 15%. But guess what? We have 34% of Black individuals who are on dialysis. So obviously it's affecting us more than anything else. And then coming down to the leg, you have amputations. People get amputated. 4 people, I said, every day in this country. So these are the areas where it affects. Now, for young men, of course, one of the early signs and symptoms that they get is erectile dysfunction. The guy can't function. The wife is angry, So because, again, I'll use the word, the autonomic system, which is a part of the nervous system that regulates the things that you have no control over. It's the heartbeats, the way your brain works, the way your GI tract is moving, erection. Some of those things your brain does not, they're triggered by certain things. Now, diabetes tend to affect the autonomic nervous system. So, and there are 10 complications of them, 10 of them. One of them is described arrhythmia, like Dr. Atterley said. It causes arrhythmia. Now, there's what they call gustatory sweating. You're eating, you're sweating. It's gustatory sweating. Then you have gastroparesis. You have erectile dysfunction. You have a whole constellation of things that happens. And that's why we need to talk about this in our community. And we need to, find ways to handle this.
Excellent. Dr. Court, let's go to you. Your question, please. We want to make sure we catch everyone.
No, it's going to be quick. I was going to ask two questions, one for Dr. Louie and the other for Dr. Salam. In terms of how we consume so much carbohydrates, you think it's just socioeconomic reasons or because the food tastes so well? What do you think?
Well, again, that's why we'll go back in history, anthropology, and a whole lot of things. Dr. Kareem said something very profound: comfort eating. Why do people have comfort eating? Sometimes usually from a psychological or psychiatric issue. Comfort, because it gives you pleasure. And there are hormones that are produced from it. Oxytocin and all those things are produced. And he knows that. Now, as a people, we have gone through a whole centuries of psychological issues and stress and emotional distress that over time that is affecting the way our brain formulates. We know now that even for those who are alcoholics, if you have young individuals who, for you, all of us here, we're over 40, the chances that we would pick up alcohol and become alcoholics is very, very little, very small. But for teenagers, there's a reason. There's what they call the mutilation of certain enzymes in the brain that put them at risk for that. If those things are happening then, how about those who went through centuries of mutilation, of degradation, of you just name it? And as we came off the plantation into the houses, and we came off of where we only ate the food that was thrown out, and we had to improvise to a point where we now have access to eating. So it's not just all of that. All of those scenarios is playing into this, so that even our cells and brain cells develop a little differently. If you look at our brain cells, the hypothalamus, the ventral medial portion of the hypothalamus, the changes that are taking place that contains the words. I mean, some of us, we're doctors, we know now that if you look at our blood levels, they begin to recognize that our GFR is different from everybody else. You find that there's a GFR for others and GFR for African Americans, because these are the things that we, as each and every one of us here, are standing up for our communities. As doctors, we're advocates speaking for our communities. That the fact that they never used to pay attention to us, we will bring up the discussion so that we will also be at the table where they hear us and hear our voices and hear our concerns that bothers us and bothers our people as a DNA.
Before that,
now, so that's where those comfort issues begin to come from. Now, not just that. One of the things I begin to realize, and I see recently, for every person who comes to see me for the first time, what I do ESR and CR reactive protein, and begin to really see that for all those who are pre-diabetic, their numbers are really very high. They have no inflammation going on, nothing anywhere else. They have no fever, no infection, nothing. But the ESR is usually above 25, and the C-reactive protein is usually high as well. And those people, if you look down the road, they're becoming more pre-diabetic and becoming diabetic. So those are issues that we need to look at. Now, the second one is a relationship between vitamin D and diabetes. There are a whole lot of studies doing that. We as a people, because of our color, we need more sun. Not the early morning sun like we were taught when we were growing up. We need the midday sun, a higher amount of sun, because our vitamin D, we produce vitamin D because of our melanin, it's higher. And that has been shown, one, it upregulates your vitamin D level, where it improves your immune system. So that inflammatory process that's taking place all around your body that is affecting the pancreas, vitamin D tends to downregulate that. That's one. And it's also been shown, look at the studies, Chagas, Petal, al. 2010, 2011, 2012, 2014. There's been reports about that. Vitamin D and diabetes. It actually shows that if you are deficient for diabetes, for high vitamin D, you're more likely to have diabetes than in that. And in pregnancy as well. Those who are pregnant, it's been shown that if you have a higher amount of vitamin D, gestational diabetes is so much less in those individuals. So these are things we talk about.
Before Dr. Kareem answers your question, Dr. Kareem, can you tell me what's going on in my brain? Because if I eat one cookie, there's something that tells me I have to have another one.
So again, Dr. Aluya talked about neurotransmitters like serotonin, like dopamine, like oxytocin that are associated with very pleasurable experiences. And, you know, they're auto-reinforcing. So if you can't just ingest one, right? That's why it's very unhealthy to sit with an entire bag of popcorn or entire bag of cookies versus, you know, setting aside a smaller portion or storing your food in a way where you can't really see the snack. So removing the cookies from a bag, placing them in a tin so you don't see them, and therefore out of sight, out of mind, they're less available, right? The other thing too is, and this is critically important, and it has health consequences spanning multiple organ systems, but the impact of the stress response, particularly as it applies to the endocrine system and the hypothalamic pituitary adrenal axis, and exposure to stress, and how stress could lead to a hypercortisolic state. So you have increased cortisol, which ultimately contributes to a greater need for glucose to prepare your muscles and your cardiovascular system for that fight or flight response. And that response is meant to occur in bursts. It's meant to occur as needed when we face threats. However, when we live in an environment that is awash in potential threats or threats that we perceive by virtue of our membership in a certain group compared to others, whether it's driving down the highway, whether it's being in a grocery store or in a shopping mall, and that system is not dampened. It's tantamount to an alarm system being constantly turned on. And what that could lead to is that could lead to weathering or premature aging of your cells. And there's research done in terms of infant mortality, rates of hypertension. If you compare folks who immigrated from Black folks who've immigrated from various regions in the diaspora versus those who were born here, and folks, you know, in their native lands, whether it be in the Caribbean, whether it be in Africa, didn't struggle with hypertension, didn't necessarily struggle with diabetes, and less than a decade, sometimes as little as 5 years of living in this country, their metabolic profiles present similarly to African Americans who've spent their lives here. And an excellent resource that really goes into this is a chapter from the book, from Isabel Wilkerson's book, Caste, where she talks about the health impacts of American racism on the African body, whether it was one that originated in this land or came from elsewhere in the diaspora.
I have a question, and maybe Dr. Sprott or Nelson may be able to shed some light on this. You know, similar to cancer, we know that, you know, the same size approach doesn't fit everyone. So, you know, looking at, say, the cancer genomic experience, where we're now seeing specific markers that helps us tailor treatment to individuals with the same disease, but treating them differently with different combination of medication based on genomic markers. Is there such a evaluation that can occur in folks with diabetes, hypertension? Is there any known approach in that direction that helps us further tailor combination of hypoglycemics, the different type of insulin, the combination of different types of insulin that may ultimately influence the control of diabetes?
Patrick, I don't know the answer to the question. I think that, as Nelson alluded to earlier, if you look at the relationship with chronic renal failure, those individuals that need to be on dialysis, African Americans have a disproportionate number of individuals that are on chronic renal failure, and the combination of diabetes and hypertension. And Trevor talked about, how can you get folks to monitor and take care of their diabetes? It's kind of the same thing with hypertension. And there have been indications that if you control your hypertension, you can lower the incidence of dialysis. But when you look at both those two important factors as contributing, there still are a disparate group of individuals, African Americans, that have chronic renal failure that is really not explained by the diabetes and the hypertension. I think that the answer to the question is the ability to possibly be able to study those individuals and look at some of the genetic components that might be involved in them to look at the treatment. However, and this goes to another part of an earlier question, the food industry, I think, has been extremely, extremely important in what they are interested in, which is profits for their shareholders. And they develop products that are the combination of salt, sugar, and fat are extremely important in terms of getting people to that pleasure zone that Dr. Kareem talked about earlier. And so, it's not just what culturally we've been exposed to, it's what we are hit with in terms of the advertisers and the amount of product that is involved in trying to get you hooked, if you will, on repeat buyers. You go down the cereal aisle and look at all the different types of cereals that are there, and look at the sugar contents, and look at the healthier. General Mills and Kraft and all these other things, they will have a small amount of product, but at the end of the day, they're going to push what sells. And what sells is really related to, and they've done lots and lots of research on it, on these issues of sugar, salt, and fat in terms of how you get people to continue to buy their products. And so I think it becomes very, very important. And again, I can't overemphasize the importance of diet on all of these things, because if you can modify the diet so that you don't have these high contents of sugar and high contents of fat, and it's really the combination of sugars and fat that are important. But I think that the issue of the willingness and this cautionary note, if you look at the number of African Americans that didn't take the COVID vaccine, there's a tremendous issue in terms of a willingness of African Americans to be involved in clinical trials that can look at whether or not there are treatments that favor their genetic components. I think there's a big fear about using that genetic information to our detriment rather than to develop drugs that might be able to help us. And so there's a question in my mind about the end result of scientific data that would need to be obtained in order to come up with it, because there's a fear factor among our people about their willingness to participate in these kind of studies, especially when it looks at anything related to their genetics.
I think Dr. Sprott brought forth an excellent point in terms of the concentration of fat, salts, and sugars or carbohydrates in foods. Also look at the concentration of fast food outlets in neighborhoods. And these foods are presented as cheap, calorie-dense alternatives that are masqueraded as nourishment. And so if folks want a quick meal, they can go to, McDonald's, Chick-fil-A, Checkers, you name it, it's right there. And folks ingest the food and they feel full and they feel satiated and satisfied. And again, it's no different than that bag of cookies that's in the closet, except depending on where you live, that food might be available walking distance from your home.
Yeah. So the combined term there is calorie dense versus nutrient dense food.
Absolutely.
Well,
And again, the
if I may add
advertising that they
to-
promote and the types that is attracted to our community, there's no question about it.
So also,
to Dr. Anderson,
I want to emphasize as well.
which
Okay.
is
Go ahead, Nelson.
I mean, Dr. Anderson brought a very profound, context into this, talking about how we begin to identify areas as in, genetics and stuff in managing diabetes. And I'll take it this way. Diabetes is multifactorial, so there are a whole lot of, areas that affect the risk presentation of diabetes, but it still boils down to genetics as well. And that brings into question genetics, science, and technology. Now, we're living in an area, like I said before, COVID has made it possible for us to leapfrog 7 years ahead. And we, as people of color, especially those of African descent, must be engaged and also be informed about the prospects of what science is offering for us to help us in identifying, managing, and treating diseases that are peculiar to us. Because again, there are things in the prospect, there are things in the future, in the horizon coming. But how many of us are there? And that's why we're having this platform where, thanks to Dr. Omar Bey, has created this for us to present to our community so that we can, for those who are listening out at home, encourage our younger ones to go into research, into medicine, into public health as well, because we all would have to do this together. Now, coming to the nitty-gritty of the science in it, we hear what's going on with artificial intelligence. How many of us know how artificial intelligence in the future would affect how we manage the disease we see today? Like I always say, the future of science is here. The problem is it is not evenly distributed. Why? Because we have to get involved. And nobody's going to pull us in. We have to knock at that table and get down there as well, meaning raising young ones to get into that space. Now, we hear artificial intelligence, we hear blockchain technology, we've heard about CRISPR. How does CRISPR affect how it's going to relate with us? We know when the technology of CRISPR came up, and for some of you who don't know what CRISPR is a genetic module that they use in identify certain areas where a disease is. If the disease is here, they identify it and they go there like a scissors, cut that portion of the disease off and replace it with another genetic component. And so it was actually first described by the Japanese, but then some guys in Massachusetts took it over and ran with it. And we know that somebody in China actually used CRISPR to engineer and produce a girl who was born in China. So this thing is here, it's working, they're using it. But CRISPR was actually first used as a disease solution for sickle cell. Sickle cell. If you know the genetics of sickle cell, but then that's by the way. So why am I saying this? Bringing what Dr. Anderson said, what is the future of disease and how we approach disease and how we need to get involved in managing disease in 10, 20 years. What we do now may be obsolete. Now, how many of us are there? You understand? So, I mean, there's mRNA technology, there's a whole lot of things. There's what they call, now I'm having a brain block, where you have genetic, maybe you'll come to me, micro machines that are coded with coded materials.
Nanotechnology.
Yeah, nanotechnology, yes. Nanotechnology that would identify certain disease components in your body. Maybe they'll identify, the defect that produces bad beta cells, bad cells in the pancreas that cause diabetes, or the ones that cause kidney problems. That's the future. Those are the things that are coming up. But how many of us of color are there? We must raise new ones to get in. so that we can be effective.
Well, the future is computers, AI, those type of things that we, as you stated, must be at the table, because once these things are developed, no one's going to make sure that different cultures, I should say, are attended to as things are developed and invented, unless that culture is at the table. And I hate to say it, but it's true. Dr. Salam.
So two things. I think both Omar and Dr. Aluya Nelson are talking about, it reminds me of the play Hamilton and the importance of being in the room where it happens, right? So that's critically important. And to that point, Dr. Aluya mentioned encouraging the young ones to get into this space. I'm going to share a tip. This is for the audience. Anyone who has children or grandchildren who aspire to become physicians, scientists, anything in a STEM-related field, I have a tip. Number one, when you're studying science, it's important, any subject that you're studying, to do your best to make it relevant. So the nerd in me, every Tuesday, I purchase a New York Times for the science section. And if while you're studying your science classes, you could do this in high school and in college, try to make connections between what you're learning in your classes and what you're reading every Tuesday in the science section of the New York Times. Moreover, it's that section that has expanded my vocabulary more quickly than any other. And it's I'm old school. Many of us here have a surplus of gray hair. So I enjoy the tactile experience of a book or a newspaper. But the science section of the New York Times, which is published every Tuesday, if you can take what you're studying in your genetics class or in your biology class, when you're learning about cells and the nucleus and DNA, and you could connect it to something like CRISPR, that could help cement those memories, that would make that experience more enjoyable and relevant, and finally make more clear connections in terms of where you're headed. What am I doing this for? And the more you can discuss these things, the more facility you develop with these concepts, and you'll get better results in your studies.
You know, to your point, Dr. Salam, you know, there's a saying that out of the mouths of babes and suckling. So the question was asked to me, G-pop, my little granddaughter called me G-pop. Why is the pepper red and why is it green? Genetics, right? So, you know, the things that the subject matters that we take for granted, it's you know, to your point, you know, to take the science and make it relevant to our everyday lives.
We must also take the science to our elementary levels. And what do I mean by that? We take it to the high schools. I think, you know, there's a cutoff, there's a dichotomy between that stage. And we know the whole gamuts of what's going on there. But we must, those of us at the top, must reach back down to pull those who are much lower up and create a platform to identify those who have the capacity and can create the trust to go into science. Because a whole lot of our kids want to do that, but there's no space for them. And we must begin to create that space. And we have to advocate for that. It may be uncomfortable. It may be, we're also busy, but we have to find time for this, because that's the only way we sustain ourselves and sustain because down the road, 10, 20 years from now, there may not be a lot of Black men who will be in medicine. We'll begin to get really scarce.
You know, Dr. Kareem said he's old school, and he reminded me last week that when I was in college, he was only 1 year old. So I'm real old school. But I think, you know, the studies of what we're talking about show that, you know, for the Black male in medical school in 1978, I graduated in 1977, it was 3.1%. And then in 2019, it's down to 2.9. If we're not for the number of Black males in predominantly African-American medical schools like Meharry and Howard and Drew and Morehouse, it would be down to 2.5%. And if you look at what's been going on in schools with COVID and access to education, it's really horrible. And given those kind of low numbers, you then extrapolate to, well, what percent of the US American medical schools faculty is African American? It's just horrible. And so, and it's usually where a lot of the research dollars are funneled, and they're funneled into, you know, biomedical sciences in the big, in medical schools. And usually it's funneled primarily in the top medical schools where African-American faculty is even lower than it is there. So, you know, when you talk about trying to get African-American people involved in clinical trials, their ability to have faith in their doctors, which they do, and thankfully they go to African-American doctors, but to go to someone who's actively involved in clinical research, looking at these kinds of issues, it's tough. And again, outside of the National Institute of Health and some of the others that look at funneling research dollars, a large amount of research dollars is coming from drug companies. And there they go to individuals and you know, unfortunately, not a whole lot of African-American involved in clinical research for these pharmaceutical companies. So there's a, you know, we're trying to encourage African-American males and African-American females as well to go into medical school. But we also need to have these institutes of higher education really commit towards developing and increasing the amount of diversity. I mean, what you've seen over the time is that the African-American percent of the population has gone up beyond the 10% to maybe 15%. Latinos are even higher, 35%, but there's not an adequate number of Latinos in medical schools, and Native Americans or Alaskans either. And so there's a tremendous dearth, and then it really needs to be a big push to try and increase these numbers, but it's got to come from the top. And we've got to encourage folks to be interested, but these institutes need to be accepting of individuals to become physicians.
We're okay. This has been an engaging, such an engaging topic that we went through our halftime, but we're not going to worry about that. We're going to keep going at this particular point, and we'll finish it up at the end. We'll deal with what we should have done at halftime. There is a question, and just to preface this, I want to ask one question more on diabetes, but I wanted to cover COVID and the variant and the new variant before we end today. So just keep that on the front of your mind. There is a question: uncontrolled diabetes is the leading cause of death and disability in the U.S. So what can people of African American descent expect? And I think we've touched on this, but we haven't talked. We've talked about, you know, the lower extremity amputation. We've talked about the eye problems. We've talked about the heart attacks. But what about death itself? I mean, coming to from that point of view, we are losing so many. And even with COVID, understand, and with me making rounds in the ICU on a daily basis, those who come in overweight, those who come in with diabetes, hypertension, heart disease, any combination of that, and renal disease are the ones that have the highest percentage or the highest chance of dying. And that's our population of people. So what can we expect? And this is what the question is asking: what can we expect as a people if this is what we're having today? Can some of you chime in on this?
So, you know, Omar, let me speak from the women's health perspective. We know that obesity is a contributing risk factor to several cancers, of which breast cancer and uterine cancer is just a few. Part of the confounding issue is, you know, diabetes, hypertension, obesity, all these that are linked, also influences our ability to take care of individuals who, by virtue of those same problems, are at risk for developing that primary disease. Our approach to surgery is influenced by obesity and diabetes. Everyone knows diabetics don't heal very well. The obesity leads to lack of physical activity, and that's influenced by other things. And as a result, it often is difficult to control the blood sugar, get that hemoglobin A1C in an acceptable range where we can safely say we can inflict that controlled injury and the patient will recover. It influences cardiac function. I sent a diabetic to Dr. Atherley for cardiac clearance, and he looks at me and said, listen, if this was a heart transplant, I would recommend an operation. It's called a transplant. But now that they have this disease, why should we hold back? And then he does his very best to optimize the cardiac function, because now, the issue of diabetes and obesity does influence what happens in anesthesia. So it's not just black and white. There is so many shades of gray where these entities influence the outcome. Something when we talk about access, right? Access to healthcare. Someone who lacks mobility because of obesity related to diabetes. So they have struggled to get to the hospital. They get there, they're frustrated, they can't get around, and they just turn and go back home. That's where they're comfortable. And they suffer in silence. So for me, from my perspective, the inability to gain access as a result of this predisposition is paramount.
Speaking from the childhood perspective, I think what we've seen, especially in large urban areas, is a focus on testing and not so much a focus on getting our children involved in physical activities. And so physical activity and using sports as an element to get folks active. It's a little better in the earlier years, less so in the middle and the high school, specifically among girls. Sometimes it may be related to, and I don't want to sound sexist, related to the hair and things like that. But I think that there's been an overall decline in the ability of the African-American kids to access sports and physical activities in an organized fashion. And it's only a small percentage of those individuals that do get involved that sort of benefit from it. But overall, there's been a lack of attention provided towards that. The same thing could be said about music and the arts, but for physical activity, which is a major contributor towards what we've been talking about today, that's not been a main focus at all. And I think that the people that you talk to in education said that the hammer and the focus is on standardized testing at the various grades, and everything else is less important.
To quickly piggyback off what Dr. Sprott was saying, I think all of us should advise our patients, those who have a modicum of mobility, to start walking. When I lost a significant amount of weight years back, one mantra was, if I have to drive to it, I'm probably not going to do it. And so if you have safe spaces where you live, you should walk. We all have to run errands, go to stores, park our vehicles. You could park farther away, but anytime you're moving, you're improving your health. So it's important to walk. No one's expecting you to leave this webinar and run a marathon or a 3K or a 5K, but movement is critically important. Walking, getting your heart rate up, and that's something we all have to do, so we might as well benefit from it and make it a routine or a ritual, just like brushing our teeth, taking a shower, and the like.
We look at factors that are modifiable in terms of the risk for heart cardiovascular disease. And of course, some we can, some we can't. But we look at, there are about 9 factors that have been identified in a very large worldwide study. see those that are negatively influencing the occurrence of cardiovascular mortality, death. And we know the obvious one, smoking. Diabetes is high on the list. Diabetes is as bad as having had a heart attack. And we know if you've had one heart attack, you are at high risk for having a second one. If you've had diabetes, your risk is as high as if you've had a heart attack. And it is one of those modifiable ones. It's important also that they identified the positive ones that we can do to modify our risk. And we talked about exercise. Regular physical activity is high on the list of things that we can do. And we do not mean, as I'm glad to emphasize what you mentioned, Karim, and that is that we don't have to run marathons. We should not, in fact, do excessive activity, but activity on a regular basis, which is a moderate intensity and not necessarily high intensity, is what we need. Of course, the other things that we can do that are under our control, and I'm not sure how we recommend this, but regular alcohol consumption has clearly been documented now. Regular alcohol consumption, not excessive consumption, has been clearly identified as a modifiable risk factor for which we can help. And of course, proper dietary aspects, which again may relate to things like diabetes, but in general, appropriate dietary consumption of fruits and vegetables has again been statistically related to improving the risk for cardiovascular disease. So the things that we can do, and should encourage for children and youngsters to also follow.
And aid in
I'd like to
cancer
say that
prevention.
My father died of his third heart attack at age 47. I was 12 years old, and he was a smoker of unfiltered Camels. And so avoidance or not starting or quitting smoking if you can. I was afraid of when I was approaching 47 about that, but you know, I'm now considerably beyond that. But smoking, I think, is a horrible thing that can damage your lungs as well as contribute towards heart attacks.
Patrick?
For me,
Yeah, no, that was a question I meant to ask earlier when we talked about asthma, was the consequences of uncontrolled asthma, the damage that can occur in the lung.
okay.
Yeah. You know, when you're talking about the inflammatory component to the airways, especially the small airways, as Dr. Sprott had stated, and you're talking about the mucus and the plugging that happens in these airways, understand that bacteria loves mucus. And as the bacteria grows and as that chronic irritation continues throughout life, usually it's not affected. This component is not a part of it when you're a child, but when you become an adult, it's we can't divide lung disease into one entity, meaning that asthma it may start off as asthma. But if you are a welder and now you're inhaling smoke for the last 20 years, or you're a construction worker, or you catch bronchitis on and off every winter, or you've had pneumonia several times, now it's not only asthma. Now it's, you know, bronchitis. Now it may be emphysema if you're a smoker on top of it. Now it may be, you know, things like bronchiectasis. People get tuberculosis. There are other things that cause, as you can come about as you live in the years, that changes the aspect of what your diagnosis is truly is. So it's an ongoing dynamic as far as medicine and health is concerned. And I think diabetes is the same way. It may start off as one animal and end up as another animal because of the things that it affects. So, you know, one thing I always tell my patients, one aspect will always happen. There will always be change. And we have to be about directing that change, number one, taking care of that change, and making sure that we keep things under control so that life is meaningful, that longevity is there. And we're here to be with our grandkids, to state that, wait a minute, I'm going to make sure that I'm here and functioning, not that I'm here, I'm 60 years old, I'm alive, but I'm in a nursing home. No, I want to be 60 years old, expecting to get to 85, 90 and functional. And that's what we should be about for our culture and our people. Okay.
Patrick, asthma, by definition, is sort of a chronic disorder disease, and it is obstructive and it is pulmonary. So we hear about COPD, but chronic obstructive pulmonary disease. Now, most individuals that have asthma will not develop some of the things that Omar talked about in terms of bronchiectasis or destruction of the airways and breakdown and everything else, but some may. And so you're talking about probably the 5 or 10% of the worst asthmatics who continue to have asthmatic symptoms throughout their lives, who can go on to develop those kinds of changes that are I'll call a death spiral. And so I would say that and my philosophy has always been that if you have a problem, the earlier you deal with it, the easier it is to reverse it. Even when you have an asthmatic attack, for those individuals who may end up getting to the hospital, they're moving towards that hospitalization even before they have symptoms. And so there are things that you can do to sort of see whether or not you're getting worse. And when you first start to wheeze or you first start to cough, if you give medication, you can reverse it. But if you wait too long, then it becomes difficult for you to reverse, and then you have to get hospitalized and go through that same sort of a thing. And the same thing goes that if you get hospitalized for asthma and you have repeated hospitalizations, it becomes very, very important for you to have what we call for kids a asthma management program, where you have to have a plan that talks about when you have these symptoms, you start to take this amount of medication, you start to add another medication, you add the steroids, and you increase it. So it becomes as important for those that have severe asthma to manage their asthma so that they don't get to the point where they may end up having COPD and may have those kinds of things. So there's a certain overlap that can occur, but we're talking about the most severe asthmatics. Again, I'm pediatrics, but I have friends who have bad asthma, and I just kind of follow them. And those, Omar sees those because they get referred from their internist to the doc. But indeed, they kind of have to manage their asthma as much as the diabetic. They need to be on medications every day. They may need to alter them, but they need to be on medications every day to keep them from getting sick enough that they get hospitalized.
Okay, Doc, make it short because we run out of time.
It's going to be short.
Things that I want to cover.
It's going to be short. One of the things that I emphasize is that in our country, we are only sick if we have pain. And so often we see diseases in the end stages that we can't do a thing about it, because notoriously people from the Caribbean, they're only sick when they're hurting. Please.
Yeah.
You can be sick and dying and don't even know that you're sick.
Yeah, Dr. Court and I had a run of patients this week that exemplifies exactly that. These are folks who are coming in with bad cancers and they only show up because they couldn't breathe. Pulmonary blood clots to the lung, fluid around the lung. Dr. Bay, you've seen some of those patients, and they only show up because they got to that point.
There's one thing I want to say. We've covered diabetes. We didn't quite cover as intensely as I would love to have pre-diabetes. Understand, I'm just going to say 2 things about it. Number one, pre-diabetes is curable with weight loss and exercise. That's all we have to say. Weight loss and exercise. Let's get that into how we're thinking. COVID. Let's cover this. I know we've run over time, but I think it's so important at this particular point with the new variant that's out, that we at least as a group of Black physicians cover COVID and the new variant. Now, I'm not saying that we're infectious disease physicians, but we do come in contact with patients that ask us questions about it. And I think we should just have a general conversation about this COVID, how we're treating, how we're talking to our patients, okay, about what's happening. Can we start it off, someone? Because I know I have a lot of things to say, but I want the group to chime in on this.
I'm going to start
I'll start with the history of it as usual.
But I just
Hold on. Okay. Dr. Aluya and then Dr. Sprott. Let's rock.
So the history of it, as we know, of course, people say it was discovered, and I hate to use that word. I say it was identified in South Africa. But as we know, it has now become an almost a black man's disease. And that's the narrative that's going on. Because it was found in South Africa, identified by South Africans, and we ought to actually give them the most honorable respect. The South African scientists who were able to identify, delineate the disease, tell us the dynamics of it and the genetics of it. We need to give them props for that. But unfortunately, what is happening? They're banning South African countries, Namibia, Botswana, South Africa, Zimbabwe, their citizens from going to Europe, rather than saying, you know what, you saved our lives. And then they just added Nigeria to that list. And that's where I'm from. But you begin to wonder why. You understand? So, like Gutierrez said, this is tantamount to travel appetite. And that's exactly what it's beginning to look at. And that's the politics of it. But coming to the disease itself and the genetics itself. In fact, those great guys who did that said it has about 50 mutations, 50, of which on the strand,
the spike protein.
on the spike, there are about 32 mutations on the spike alone. And on the receptor, there are about 10 mutations. A whole lot of it we know, but a whole lot of it we don't know. Now, the issue is this did not come out of the Delta virus or the Delta variant, which is still predominantly here in the United States. It's totally different. It actually came from one of the variants that came sometime mid last year, but over time mutated and got all the mutations that it has. And who knows? Things are bound to mutate. That's what viruses do, because like we alter our environment so that we can survive. So viruses alter their DNA so that they can survive. And how do they survive? One, they survive by escaping your immune system, including your vaccines. So the question is, one of those mutations that we begin to see, three questions they're asking. Is this escaping the immune system? Is this escaping the vaccine? That's one. Two, infectability. Viruses do that so that they can spread their DNA, pass their DNA to their generations, just like we pass our DNA to our generations. They do that. So now, how effective is this one? It is very effective. Now, it's been said that it's 500 times, 500% more effective than the one that came out, the original virus that came in ab initio from Wuhan, and it's 4 times more effective than the Delta virus. Now, the third aspect is what? The severity of the disease. So those are 3 questions that we need to answer. Now, the severity of the disease is one thing that they've not been able to answer yet. And some of those, codes from the genetic codes that they highlighted haven't told us that yet. But as we know right now, most people who are in South Africa who have been infected with this have not been showing that much severe symptoms yet. So hopefully it doesn't get that bad and it stays like that. So it is not a black man's disease. It's not an African disease. We need to stand up and change the narrative. Thank you.
Dr. Sprott.
Yeah, I just will amplify a little bit in that a virus is, in order to reproduce itself, can't do it on its own. It has to be within a living cell. And so when you get a viral infection, you're getting that virus from someone else where that virus was in the living cell. For the most part, it's a respiratory virus. So someone coughs, you inhale it, and that's how it kind of spreads. And so the issue of a new variant coming out, they somewhat like the hurricanes, they started out with alpha, beta, gamma, delta. You had to do all this for when we pledged. But so there will be other variants. And again, the vaccine was never designed to prevent you from getting infected. What it was designed to do is to prevent you from getting very sick, getting hospitalized, or getting on a respirator and dying. And for the most part, that has been very, very, very effective. And most of the people who have gotten the vaccine and they're saying, oh, they got the vaccine and got infected, well, it wasn't designed to prevent you from getting infected. And a lot of the people that got fully vaccinated and then got COVID, very often it was mild. And indeed, your immune response went in high gear to deal with the fact that you got infected. And I think that those individuals who were fully vaccinated and got COVID had mild disease and really had a boost to their immune system because of that exposure. And so I think that this, and again, Nelson, this whole belief about, oh, the Delta virus is 10 times more effective than this and that, I don't know how they come up with that, okay? In order to really come up with that, you say, okay, let's take 100 people and let's expose them to the virus and see how one virus responds to another. No one's doing that. They come up with these models, which I'm not sure make a whole lot of difference. And the main thing is this, is that indeed, if you've got fully vaccinated, and then if there was some waning in your antibody, I'm not so sure that the waning in the antibody means that you're not yet primed to deal with it when you get exposed. But if you get a booster, you now have even higher antibody, or if you've gotten infected, even more higher antibody. And so the idea for all of us, I'm sure most of us have already gotten boosted again, is you don't become so concerned about being exposed because you shouldn't get very sick if you get it. And so this whole issue about making, and again, this has been politicized from the very beginning about the China virus and the Wuhan virus and this and all of this. We're in a worldwide community where people travel back and forth, and if it's something that's somewhere, it's going to be somewhere else, and the virus is just patches on to wherever is there, and then it goes and it spreads. And so I think that the main thing that we should be putting out there is that, yes, these vaccines don't prevent you from getting infected. They do prevent you from getting sick and dying, unless you have a problem with your immune system where you can't really respond to it. And those are the individuals that tend to have problems. If they have problems with the immune system, are they taking medications that dampen the immune system so that they can't respond the way that they ought to be responding to the vaccines? But I think that for everyone out there, if you got fully vaccinated and you get the booster, you get the booster. And doesn't mean that you shouldn't do the things that should try and protect yourself, especially if you're up in age like some of us are. You should still take precautions, but you should feel somewhat protected that from, if you get it, that you won't get very sick.
I'll quickly add, of course, I'm going to emphasize the importance of vaccination and getting the booster since it's more widely available. However, many of us have people, some are in our families, some are very close to us in our social networks, who are not vaccinated. And this could be a tremendous source of frustration. What I would ask us to do is to leverage those relationships and continue to educate these folks. Don't cut them off. Don't stop talking to them. And then you could even ask questions. You could leverage the relationship by asking the following question. You've known me for X number of years or decades. How many times have I failed you? How many times have I willfully advised you to do something negative, toxic, or harmful to something as important as your health? And hopefully, the lion's share of those answers will be never, or no, or zero. And so exploit those relationships. Yes, I said that word, exploit those relationships, share your expertise, don't cut these people off, and, wear them down with the positivity and just kind of, call them out point blank. I've never harmed you before, nor do I intend to. So you can encourage them to make better decisions for their health in the setting of this global pandemic.
And Kareem, the other important thing is that since probably the summer, almost everyone that's being hospitalized and being on ventilators are those that are unvaccinated. And there still are millions of folks that haven't been vaccinated. And those are the ones who are taking up the hospital beds and the ICUs. And we're now hitting the point where it's starting to get cold again. And we're now, last year we had very low influenza. We're starting to see influenza, which means that people are doing things that allow for it to spread that they weren't doing last year. And so I think that the individuals that aren't vaccinated are probably at a higher risk now. as long as the weather remains cold of getting it, and then suffering some of the consequences of it.
Sadly
And I
enough,
have to say, you know, there's a population of patients that really need to pay attention, and that's the unvaccinated pregnant women. We've had a few in the hospitals. This is leading to early deliveries, which certainly influences the child's development. But these patients, when they have surgery and get intubated, they don't do well.
One quick word to some of those younger people who feel that even if they do get the illness, that they don't have the multiple risk factors, low immune systems, etc., and that therefore, why not? It's not a big deal if I get it. I know I'll get over it very easily. I would like to caution them against such thinking. You do not want to get the disease because we are still unaware of the long-term consequences. In fact, we are aware of some deleterious consequences of apparently mild disease in people who think they have fully recovered. That may not necessarily be. It is best to avoid it. The vaccine is of paramount importance, and continuing the other protective measures that we've all talked about. So please, I try to advise everyone to get the vaccine unless there's a really significant reason not to.
Sadly, COVID justice could be swift and lethal and deadly. So it's just not worth taking the risk. You really, it could be the end for some folks.
I'll just say, you know, from a critical care point of view, I make rounds to the ICU every day. Dr. Sprott, you are 100% right. Those people who are in the ICU on the ventilators and are not making it, are not, I may say that again, are not making it, are those who are not vaccinated. We rarely see someone come to the ICU that has had proper vaccination. Rare. So, and Dr. Anderson, again, we worked on those patients that were pregnant that has COVID, and unfortunately, you know, the end is not. It's not a good story at the end. So I implore you to get vaccinated.
You know, we've extended the armamentarium to these patients when it comes to life support. Now we have pregnant women on a lung machine, ECMO, for weeks, trying to just get them appropriately oxygenated so we can extend the pregnancy so that neonate can become viable. You know, we don't know the long-term consequences on these youngsters once they're delivered. And the mothers, again, these children are going home without mothers.
All right.
And the issue is, you know, because they're on this machine that functions for their heart and their lungs, they always aren't able to make the oxygenation perfect. And these kids are exposed to these low oxygen states and therefore at risk for having issues with their brain development. So it's really, really important. And unfortunately, I think all of us have had talks with individuals that they just don't want to hear it. They don't even want you to talk about it. It's almost like politics or religion. You know, they have their own beliefs, and some folks say they're woke. I don't know what they mean by being woke, because it sounds like they're in somebody's daydream.
Well, before I end, one thing is for sure, vaccines do work. And I've asked a few of my patients and those who are almost recalcitrant about taking vaccine. And I said, listen, when's the last time you saw polio? They don't. They're like, I haven't seen. When's the last time you saw measles or chickenpox? Well, guess what? Those things still happen in other countries outside of the United States, but they're not happening here. Why? Because the majority of people, are over 99% of people, were vaccinated. So because they're vaccinated, we were able to protect one another. So that even if somebody from outside this country who's not vaccinated comes in, you're protected. That's how we've been able to do this. We heard about Zika, what Zika was doing to pregnant women. They took care of it, and nobody hears about it anymore. So if we're going to fight this so that it doesn't become like the flu vaccine, who had 100 years to mutate and do all the things it can do, because up till 1949, when we started in the late 40s, when we started having vaccines, there was nothing. So it had over 40 years head start from us. But right now we have this vaccine. So the only way for us to get rid of this, so that we would no longer add on top of the 30,000 people who die from flu vaccine, flu infection every year, 30,000 in this country. Most people don't know that. So if you add COVID on top of it, that becomes perennial, then it becomes a big issue. So the only way to do that is for all us to get vaccinated.
All righty, all right.
And do it
Excellent, excellent. I think at this point, we're going to have to wrap it up. We're about 17 minutes over, and I'm just so appreciative of each and every one of the physicians coming on and just being a part of this webinar. You have no idea the joy it brings to my heart that we come together and do this every second Saturday. So I'm just extending an absolute joyful, thank you to each and every one.
Dr. Omar, before you go, who's the little, junior?
Oh, our little cutie over here, Dr. Anderson. You gotta say, who is this?
So this is a Yira Rose, who affectionately calls me G-Pop, who wants to know why peppers are red and peppers are purple, because purple happens to be her favorite color. So say, hi, fella, hi, gentlemen, how are you?
What's her name?
Hello.
Your name is Ayira Rose.
Wow, that's a beautiful name.
Love it.
Beautiful.
Beautiful name for a beautiful girl.
Do your hair?
Say that again.
Did G-Pop put those beads in your hair?
Say, mommy did. Say, no, mommy did.
No, Mom did.
Oh, okay.
Oh,
He's
beautiful.
good enough. You know, he operates on tiny things. See, I'm sure he could do those braids.
I can tell you this, if I touch this hair, mom would say, don't you touch my baby's hair again. Yes.
Let's not get G-Pop in trouble.
All right. All right, guys. So thank you. Let me end it this way. Number one, I didn't get a chance to thank OBHealthy for allowing us to bring this webinar to you every second Saturday at 1 o'clock. Understand, OBHealthy basically is they have a health app, and that health app is eating healthy, weight loss, and wellness. And you can download the app. Just go to your app store and use the code 365 when you're downloading and hit apply, so it will apply to you and you can get it for free. And this app is for health and wellness. Please download it. All righty. The most important thing that I can say, and I will say this each and every time we meet, please do not change any aspect of your medical care until you consult your physician. Only your doctor can truly take care of you. All right. And you can see all of our past webinars on YouTube. Just go to YouTube, OBHealthy, and check out our past webinars. And the last thing I want to say is just, again, thank you for the audience and thank you to the physicians. Until next time, second Saturday of each month, we will be here. Be here or be square. Thank you, everyone. Goodbye.
Okay, good.
Goodbye. Peace.
Bye.
Bye.
Bye.